Okay, so what we have here actually is a blood investigation summary. So we have the baseline before patient was started on anti-TB drug, which is pretty much normal, and the 2 weeks after it was started, which on the 10th of February, he actually we checked the LFT was normal. So however, after that, he at 6 weeks time is when he started to present with rash. He was very much unwell, and then lymphadenopathy, and the blood count shows that eosinophil is 7.9%, and the ALT it was initially 400 with high GGT as well. So there's an injury to the livers, and then at this point. We noticed that on the 14th of March, which is about 3 days after that, the eosinophil actually 0. And however, the ALT transaminitis is worsened, despite at that point we already stopped the offending drug. So so we are thinking he actually has DRESS or DIHS, the newer term. Proceed further. As you can see down there, bolded in red, the ALT worsened actually up until thousands. The GGT also raised, and the bilirubin also raised. However, the eosinophils counts back to normal on the 17th of March, as you can see in this column here. So later on, the ALT worsened. The highest is actually on the 27th of March, which is 1500 thousands, and the GGT also high up at the 300s, and the bilirubin also high until 100 plus. So subsequently, the LFT improving actually to 800, 500, 200, and 146 is improving. So back to this patient. All over, he actually took 45 days to recover. And then in view of the TB treatment, which was just given for 6 weeks, we actually want to treat this patient for tuberculosis. So we started rifampicin and ozoflexacin on the 5th of May. So mind you, at this point, the LFT is normal. And then, however, then we subsequently added isoniazid. So, however, after that, he developed transaminitis after adding the isoniazid, which you can see from 10, it jumps to 279. And that is worsened actually. So because of that, we stopped his anti-TB, and then we have to do a skin prick test, and we found out he's positive to isoniazid but negative to Alzac-E, rifampicin, pyrazinamide, and ethambutol. So in view of the skin prick test, we restarted this patient with Alzac-E on the 14th of July 2018. However, 2 weeks after started Alzac-E, we noticed that he has transaminitis again. And then we also noted that he has high eosinophil gains at 7.6%. So because of that, we're thinking this is not suitable. He might have drug reaction to Alzac-E, so we stopped actually. So as you can see that progress further, after we stop the medication, the LFT pretty much back to normal. Okay, after a few while all waiting because of drug reaction, his MTB culture and sensitivity comes back and is consistent with Mycobacterium tuberculosis, complex and sensitive to AHRS. So all anti-TB, mind you that it already stopped after 6 weeks. This is just to recap what happened. And then 42 days after the resolution of rash, or we treat as DRESS, he was rechallenged with rifampicin and ofloxacin. And then we added on the isoniazid, but developed hepatitis after 2 weeks on isoniazid. So we did a skin patch test, and then we noticed he's positive to isoniazid, but negative to Alzac-E. The Alzac-E actually started with sequence of rifampicin, ethambutol, then pyrazinamide. Despite that, he still developed rash and hepatitis 2 weeks later. So this is actually easier to see rather than the timetable just now. So as you can see the timeline here, on the 20th of January, he actually was started with accurate 4, and 2 weeks after that, the LFT repeated was normal. And then 6 weeks after that, he started presented with rash and transaminitis, and there's a high eosinophils as well. So we stopped his anti-TB. So we noticed that there's a worsening transaminitis up until 730, and it peaks after 16 days to 1500,000. And then after that, subsequently, the liver function improving, and then it improved further, and the rash also resolved after total of 45 days and recovered. So at this point, the ALT is 70. And then 10 days later, so we thought actually he recovered, so we started back his another second line anti-TB. We added the ofloxacin, so we found RO. So continue with the summary. So we add, because there is no reaction, so that's why we added isoniazid. But 2 weeks after that, he developed transaminitis again, so we stopped the HRO. But 1 week after that, the LT worsened. So that's why we decided to do a skin prick test, H positive, but RZE is negative. So that's why we start the RZE on the 14th of July 2018. So, but unfortunately, he developed hepatitis and rash after 2 weeks. So we have to stop the RZE again. And then we noticed when we monitor his blood counts on the 4th of August, which is about 5 days later, there's a high eosinophil 7.6%, and the LT also is at 349. So, so now we are like, from all these timelines, sometimes the eosinophil was raised, sometimes it was normal. Actually, Prof. already mentioned it's not necessarily high eosinophils. So, but actually we query whether actually is it really DRAS, whether he actually fulfilled the criteria for DRAS syndrome. So we actually we found out in the up to date there's like scoring system to diagnose DRAS. So basically, but when we look back at his case, he has enlarged lymph node. He actually, eosinophil not very high, it's just 0.8, and then he has a rash, organ-involving hepatitis. So all in all, he just actually had a 4, which is just probable. So maybe it's not a DRAS actually. But sorry, it's possible DRAS. To progress further, after 2 months, we stopped the anti-TB actually. The symptoms resolved. Basically, he has no more fever, no more cough. The rash, of course, resolved already, but the weight is actually similar. So we need some kind of radiological assessment. So we repeated the CECT thorax on the 10th of September, and we noticed that there is a regression of the mediastinal lymph node. So this is CECT thorax. So as you can see, this is the initial one. You can see there's a paratracheal lymph nodes, lymphadenopathy, and after that in the September, it's actually improving. So the other slides also pretty much the same. There's an improvement of the lymphadenopathy, and similar here at the subcarinal level. So his blood result at this point actually is normal. So I'm thinking whether do we have to restart the treatment back, because actually he just got like 6 weeks treatment of anti-TB, and the anti-TB culture is actually positive. So what I'm worried is because the standard duration of TB treatment is 6 months duration, and with intensive phase of 56 doses of the 4 agents. And the maintenance phase is 112 doses with 2 agents. He just completed 6 weeks with accurate daily 3 tablets. So whether should we restart the treatment actually? What I'm worried is if let's say we stop the treatment, he might actually develop what we call MDR TB. So at this point, I think I will get my superior discuss with the respirologist and ID physician whether we should start. But the MDR TB will be my primary concern.
Farhana, can I just double check? He was not given steroids for his dress, right?
He actually was given
He was.
he was lah.
Oh, yeah, he was given steroids. Oh, okay. And the test is actually a patch or a prick test because
It's a patch.
it should be
It's a patch test.
It was patch, not prick, right?
Yeah.
Yes. Okay.
So so just want to show that we have a second line anti-TB to be started because he has pretty much allergies, drug reaction to the first line anti-TB treatment. So we have like A, B, C and D group of anti-TB. First we start with fluoroquinolone, second line injectable agents like amikacin, kanamycin, and also the second line agents like ethionomide and cycloserine. Because we have all this, and the least that can cause drug reaction actually is a levofloxacin. So he actually was started with these drugs actually. But however, once he was started with levofloxacin, he developed transaminitis, which is about 1 week later with ALT from 19 jumps to 600. So we stopped the drugs. So this is timeline that show that 1 week later, after we started levofloxacin, he developed another transaminitis. So
thank you, Dr. Farhana. I think the case has become more and more interesting because we need to treat this patient, and patient developed complications to first-line anti-TB. In fact, even I think ethambutol, she was not able to tolerate because of a vision issue. So perhaps maybe we can get the expert panels to comment and to maybe to give us some insight as to what are the approach that they think will be feasible for this patient. Maybe we'll get perhaps we get Dr. Andrea's opinion.
Thank you, Ian, for choosing such an interesting case. So I think this is a difficult case. At this point, a few questions to answer. Number one, do we doubt the diagnosis of TB? No, we don't, because this patient has got culture that's positive. So he has got TB. You didn't show the lung images of the CT, so I'm going to assume that this is extrapulmonary TB. I don't know whether he actually had CTs of the entire body, but he certainly has got lymph node enlargement, and the TB, the EBUS from it actually grew mycobacterial tuberculosis. So in retrospect, if we had known the culture earlier, perhaps we wouldn't have given him the ethambutol, because the guidelines tell us that now you have a nucleic acid amplification test, you can actually get the turnover time is much faster. If you can find the cultures, you can find the sensitivity a bit earlier, you do not have to give ethambutol. So to come back to this patient, when we talk about completion of anti-TB, as Farhana mentioned, is 6 months, minimum 6 months, right? So when we talk about months in anti-TB, we don't usually talk about months, we talk about doses. That's the reason why in the book, there's this book and you're supposed to count the number of doses. So the full intensive phase is 56 doses, and this patient falls short even of the intensive phase. So what can happen to the patient? It's been shown that in the past, how did we come up with this regime of 2 months and another 4 months? Because we realized that at this point, the relapse is actually very low. So we know that this patient has got a higher risk of relapse, right? That's definite. Studies have shown that in Asian patients who have completed at least 6 months of treatment, they actually do get, they can get a relapse, and it can be between 2 to 3%. So we know that relapse is something that is real. At this point, the MDR part, I think it would be even more dangerous to start the treatment and have a lot of treatment interruption, and that would actually also be a higher risk of getting a multi-drug resistant TB. I think if the patient is asymptomatic and this is extrapulmonary TB, probably at this point I wouldn't be in a hurry to initiate treatment, but certainly I would probably discuss with other colleagues. So this would not be a one-person discussion. I think in the morning CME we talk about MDT, so I think at this point this would be good to discuss the person included here should be gastro as well, because there's something happening in the liver. This patient keeps getting hepatitis, right? Because I think at the very beginning, even when the patch was actually only for isoniazid, one of the rules of anti-TB would be if the patient already had very severe hepatitis, the regime that should be introduced back, you should probably consider omitting the pyrazinamide. So that's probably, there's no magic answer. All I can say is that at this point, he's not infective. So that's a major plus point, because otherwise it's going to become an issue in terms of spread if you do not treat. He's not infective. He also appears to have some form of regression of his lymph nodes. I probably would watch and wait for a bit, and in the meantime I would discuss with other colleagues and include other units in it, and to come up with some form of plan, because definitely he's unable to tolerate the conventional first line. So when you actually switch to second line, you're looking at duration of longer, right? Because the backbone of therapy is rifampicin and isoniazid. If they don't have that, you cannot stick to the 6 months of regime. It will be longer. We talk about compliance with the patient, and after what has happened, perhaps the patient might not be too keen for that. So that's probably my take on that.
So yeah, thank you very much to Dr. Andrea. Maybe we'll get Professor Adavia's input on dermatology aspect as to what's her opinion on this.
Okay, so first and foremost, of course, I look very carefully at timelines, of drug timelines, because that's what I do best. Okay, so when the patient developed the DRESS, he was on all 4 drugs, obviously. So patch, first and foremost, patch test, drug patch test, is not very sensitive. If the result is positive, yes, we'll be comfortable to say that the patient is allergic. But if the results are negative, then it's not a confirmatory negative. The gold standard in actually identifying the culprit drug is actually challenge or provocation. So that's the gold standard. So our patch test showed, we did not manage this patient, but the patch test showed positive to isoniazid and negative to rifampicin, pyrazidamide, and ethambutol. So the isoniazid is, I think, reliable. But I also look at the timeline that the patch test was actually performed quite early after the reaction. So ideally, you should wait 6 weeks before conducting any drug allergy test. But we can understand in this situation where the patient has got an infection and the infection has to be treated fast, so you can't afford to wait 6 weeks to do a test. The reason that we wait 6 weeks is actually to wait for the immune system to sort of calm down, because when we're doing patch tests, there's a condition called the angry back syndrome. It's basically because your immune system is still active. So when you get a lot of false positives due to this angry back syndrome. Okay? Right, so which is actually, of course, everybody would like to know which is the culprit drug out of the 4. Okay, so without doing any test at all and just looking at the timeline, he was challenged. So when he was first challenged, he first received R and O. R is rifampicin and O is ofloxacin. Okay, so 3 weeks of ofloxacin and rifampicin without any reaction, no hepatitis, no rash. Okay, just before that, I will just probably, I think I will summarize this patient's problem in terms of his reaction to drugs. So he has an allergy, a drug allergy, as we already see with the rash and the DRESS. He also has hepatitis, which is, I think, could be related just to the DRESS or could be part of drug-induced liver injury, DILI. So it could be a separate DILI, which is separate from the allergy. And of course, maybe even also neuropathy or maculopathy because of the blurring of vision. Right, so I think he has got 3 problems actually. Okay, so my part is only the allergy rash lah. Okay, so he received R and O, rifampicin and ofloxacin for 3 weeks. Nothing happened, and isoniazid was added. And after 2 weeks, he developed hepatitis, but still no rash. So what we can conclude from here is he actually received rifampicin and ofloxacin for a total of 5 weeks with no rash, normal FVC. So I think that means rifampicin and ofloxacin is actually safe for him. That's actually enough of a provocation test to confidently say that it is safe. Isoniazid obviously cause hepatitis because you can see as long as isoniazid is added to the rifampicin and ofloxacin, he develop hepatitis without rash. So maybe isoniazid causes the DILI, the DILI. Okay. So what causes the DRESS then? Then we are left with pyrazinamide and ethambutol. Okay. So and he was then challenged with three at the same time: rifampicin, pyrazinamide, and ethambutol. He developed rash on day 1, and also hepatitis, and also high EOS in the field. So since rifampicin we already ruled out because he had 5 weeks without any reaction. So again we are left with pyrazinamide and ethambutol. So so I think the culprit drug is actually either pyrazinamide or ethambutol. And what should we do about it? Shall we go through that now, or should we continue with the?
Yeah, so thank you very much to Professor Adawiyah. I think that was a very fruitful discussion from the panel. Maybe we'll get the from ID perspective. Dr. Patrick, is there anything that you would like to add on?
I wanted to ask Professor Adawiyah a question. Okay, so normally all skin rashes also I go to Dr. Adawiyah's unit. Anyway, so the first question I wanted to ask is for more discussion. So can we actually rule out DRESS because just because you can say it occurred around that 6 weeks period, isn't it? Rather than saying that since it's a delayed one, so are we quite confident to rule out? Although it's longer, it's better. And every time we reintroduce, it's occurring faster. So whether it's still, can we say that's number one? Second thing I wanted to ask you. So I was going to ask Professor Adawiyah anyway, so I better bring it up also. We are not supposed to desensitize in a DRESS, but we're running out of options.
Yep.
So what do you think?
So this is about like when is the actual onset of reaction when a patient develops allergy. Broadly speaking, in terms generally the antibiotics, our normal antibiotics is between 3 to 5 days of treatment, then develop reaction if they are receiving it for the first time. Because if a patient is receiving a drug for the first time, in order for them to manifest the allergy, they need to have a sensitization period followed by manifestation of the allergy. So for normal antibiotics, usually the sensitization period is about between 3 to 5 days. But if the same drug is reintroduced, the patient is exposed to it for the second time, then we expect that the patient will actually develop symptoms after the first dose. So this is in general, but there are of course some patients who just develop different ways, who has different ways of reacting to the drug. The anticonvulsants, the anti-epileptics, allopurinol in general, 6 weeks after introduction of the drug. Anti-TB, I have seen a lot of different times. DRESS in general, yes, the reaction usually comes a little bit later, not in the first week. For anti-TB, the latest that I've seen, actually, the longest duration or the duration of sensitization was up to 2 months. The patient was already in maintenance phase. So even that, that was a surprise. I didn't think it was an allergy, so told her to continue her anti-TB, but of course rash did not disappear, so finally we biopsy and it was confirmed, biopsy confirmed. So even in maintenance phase, they still can be as long as that. What was the other question?
Desensitization.
Oh yeah, desensitization. Okay, yes, again, when we are following guidelines on drug allergy, patients who have severe drug reactions, they are contraindicated for desensitization. So when we're talking about severe reactions, SJS, TEN, DRESS, AGEP, but I have to say, this is a patient in whom we have to not really follow guidelines because a lot from the majority of our patients we can follow guidelines, but there are some patients who are actually you just have to make your own clinical judgment and you can't really follow guidelines. So even though guidelines says that we are not supposed to desensitize them, actually there are people who have actually still desensitized these patients, and they report actually success. So it still can be done, but I think it has to be done really, really meticulously.
Okay, yeah, that was very interesting responses and answers from the expert panel. I'm sure everyone is very excited to find out what's the outcome of this case, right? Maybe we'll get Dr. Farhana to wrap up the case, and also we'll open up for Q&A sessions towards the end.
Thank you, Dr. Ian. Thank you all the expert panels. So, basically, the take-home message for today, number one, the most important is symptomatic patients suggestive of PTB, but normal chest X-ray must do a CT thorax. Number two, DOTS is important. Direct observation therapy is important, not only to make sure patient is added to treatment, but also to look for any adverse reactions from the medications. Number three, anti-TB drug reaction can be a spectrum from mild pruritus to severe systemic reaction like VAS. Number four, regular reassessment of signs and symptoms of TB with repeat radiological imaging during follow-up is important to see whether patient responded to anti-TB or not. And the last one will be none of the patients are similar and must be treated individually. Any treatment must be balanced with intended outcome and risk of complication. So,
due to some technical issues, there was actually another slide that was not able to be uploaded here. Basically, the decision was made not to treat the patient further because we look at medical ethics point of view, beneficence and maleficence. Rather than subjecting patients to more harm, this patient was actually subsequently monitored. And true enough, lo and behold, 6 months and 12 months of monitoring, there was no recurrence of symptoms and the patient was relatively well. Yeah. So maybe we can open up the session for any Q&A from the audience and also for the audience that are watching at home.
I think he has got a high risk of reactivation of the TB, right,
Yeah.
Andrea? Because treatment wasn't
Yes.
completed. So I wonder who's the lucky people who gets to manage him then.
He might not, he might come back with florid pulmonary TB. So for the moment, I think, so if you extrapolate data from this, right, you can say that when someone has got TB, of course the fear is actually the spread. So if he were smear positive TB, this would be a different matter. He certainly would not be allowed not to be on treatment, right? Because it's extrapulmonary TB, that's why even if you do not treat. So as I mentioned before, he will get it, like the paper showed that within 24 months, right, you will get 3% of people who've actually completed 6 months of anti-TB actually can also get a recurrence of infection. And what more so with only 46 doses. So he'll probably get it, it's just a matter of when. So I think it's important in these cases to follow up the patient so that when he does get the first inkling that something is not right, that we would actually probably, that would prompt us to do something. So I think in the meantime, what we can do would be to think about the treatment. So as Prof. Ada mentioned, the 2 drugs that we think. So maybe there might be a role for only 2 drugs and for a longer period of time, provided that he is still sensitive to it. So at some point, we will also want to repeat the, if let's say he develops lymph nodes again, or something new, we certainly would think about the resistance pattern. And this is when you're going to talk about your other like line probe assay or gene expert, other investigations that are molecular in level to make sure that he is still indeed responsive to the drugs that you're going to give him, because if he's resistant, then the treatment is different and he will be difficult to manage.
I think Dr. Patrick actually desensitized quite a few patients with drug allergy, but he mainly does it for penicillin and the cephalosporins, right, Dr. Patrick?
Yeah.
Have you done it for anti-TB?
Anti-TB, no.
No. Shall we try?
I would have called both of y'all.
Is there any role of giving steroids while you are desensitizing?
Okay. Yeah. There are actually some people actually do give steroids to sort of suppress the allergy while giving the anti-TB. Of course, when we're giving steroid, we're always worried about the infection itself getting worse. I actually personally have only tried it once. So
Did
the
it work?
steroid suppressed the rash, but not the DILI.
Oh, I see. Okay.
Because as we all know, drug-induced liver injury, they do not respond to steroid at all. That's what gastro told me. So it doesn't, no, doesn't matter how much steroid you give, the hepatitis, it will not suppress the hepatitis.
Okay, we have a question here from the audience to Prof. Adavia. So it's a concern on for delayed hypersensitivity reaction despite withholding offending drug. Steroids given up to 2 months, right, with the intent to